Good morning, everybody. We'll get started. There's some folks on Zoom as well. So we have a double header today, united by the theme of the vagus nerve. Some of you may remember we talked about vagus nerve stimulation a few months ago, and that spurred us to try to bring together two distinct clinical practitioners who are using vagus nerve therapy as a now accepted and mainstream way of trying to help patients rehabilitate from injury. As many of you know, VNS is now approved also for rheumatoid arthritis, and likely will be approved for other inflammatory conditions down the pipe. We're just starting a trial for multiple sclerosis, and I think we all need to understand this space, understand its conceptual nature, and the issues around how we go further forward. So today with us is Dr. Radha Korupolu. Dr. Korupolu is a graduate from Andhra University in India, and then did a residency at the University of Kentucky, and did her fellowship here at Baylor. She has been at UT for about a decade, from what I can tell, and she's interested particularly in the rehabilitation of spinal cord injury and all of its aspects. So she's interested not just in the motor rehab, which is the obvious part, but also in the pain management, the respiratory health, and also inflammation in these individuals, but also their behavioral health. So sort of a global perspective on how to manage spinal cord injury. And that journey has brought her into vagus nerve stimulation. And on my left, Dr. Sharrief, many of you know her because she obviously also is at the hospital, but many of you interact with her. She's a little disabled recently from a foot injury. She's a professor in the Department of Neurology and the director of stroke prevention. So actually, when I have a patient with a stroke that I see in my clinic for something else who likely has a risk for other strokes, Dr. Sharrief is the one who sees them most likely, because she's easiest to get in also, I would say, one of the easiest stroke neurologists to get patients to see. She grew up somewhere between Michigan and Atlanta, which couldn't be more diverse, I guess, in terms of an upbringing. Went to Smith College, and then after 2 years at the NIH, did her medical school at Columbia, Hopkins for residency, and then started at UTHealth about 12 years ago. And so, has been interested in stroke, transition of care and education. And then over the last now 2 years or so, we've been doing a fair amount of work together on vagus nerve stimulation. So by way of just a little introduction to this idea, right, the first paper actually that had VNS for stroke was published from here, or at least this was a major center for it, and Daniel Kim did a lot of those implantations because he was a peripheral nerve surgeon amongst his other hobbies. I think we have a lot to be proud of in launching this field in some ways. And I think it's important for us as a department to advocate for it and enhance it going forward. Well, thank you so much. I'll shut up now.
Well, thank you for having me here. So we'll be talking about vagus nerve stimulation in neurorecovery after stroke and SCI. I don't have, some of this work was funded by Mission Connect Here Foundation, and stroke studies were all industry sponsored by microtransponder, but in the SCI study, the devices were donated. So that's my disclosure here. The main learning objectives is to understand what is neuromodulation with the VNS and what is the mechanisms of VNS and what evidence do we have it, and how do we translate it to clinical practice. So when somebody has a stroke or a spinal cord injury after their acute, stay in the Memorial Hermann or UT or acute care hospitals, we follow them rest of their life. We are kind of their primary care physicians, the physical medicine rehab doctors. I specialize in spinal cord injury, and then similarly, we have a stroke team, and we see their struggles. Even though they're medically stable, they struggle to integrate in the daily life. And upper extremity recovery is so important for independence of life, right? You can't feed yourself, you can't help your children. Until we lose it, we don't realize what we have lost, actually. And in spite of current rehab and intensive, technologically so much is out there, but it is still not, there yet. Yeah, they still continue to suffer. So it is important. So that's why the research is continues to happening to how can we enhance the upper extremity or motor recovery. Rehabilitation works. They do improve. It's not like they don't improve it, but then they plateau after some time. And also the recovery trajectory is very different for each person, right? Engagement is very, very important. The people who are motivated, engaged, more in the therapy. And most of the recovery, unfortunately, happens by plasticity. And we'll talk about what is plasticity meant, not regeneration. And this persistent deficits, despite high intensity therapy, you don't realize that people continue to get therapy up to 5 years, even 10 years. And nowadays insurance is giving much more harder time. But in spite of all that intensive therapy and every effort we put, they still have deficits. Now, before we go to vagus nerve stimulation, it's important to understand neuroplasticity so that we can link the mechanisms. So neuroplasticity, what happens? The reorganization of the spared neural circuits, right? Whatever circuits are left, maybe some other circuits take over and perform the actions for the lost circuits or neurons. Synaptic strengthening of the existing synapses and the cortical map expansion of the existing area. And how does that happen? It can be a neuromodulator-driven learning as well. So in the rehab, right now, the current principles are task-specific and a lot of repetition. Repetition does help, right? Like, for example, like all these famous sports persons, what do? They repeat, right? Whenever you're repeating the same task, you become good at it. That's a neuroplasticity, a simple example. It does help, but it requires attention and behavioral relevance. For example, if you put somebody on a passive bike and you're allowing them to do it, their neuroplasticity is going to be a lot different than somebody who's actively, you add some resistance and you make sure they have paying attention and they have some effort from their side. So if there is a low effort or passive movement, it produces the weak change. Brain must perceive that this movement is important. It's like a reward system. They know that this is important for that person and this is really an important event, and that enhances the neuroplasticity. So now the plasticity also requires proper timing and neuromodulatory gating. What does it mean? Plasticity can be enhanced by these neuromodulators, acetylcholine, norepinephrine, dopamine, serotonin, and a lot of studies in animals and humans, which has already proven. When these neuromodulators release during the task, it actually strengthens the synapses, it consolidates the learning, and it makes sure that the changes persist and it registered in your brain as an important event. This is important, And timing also matter. When do this happens? Release of these neuromodulators relative to the task is very important. It has to be timed the same time, not like, neuromodulators are released before, like you give a medication, which can also do the same thing, but it has to be really paired. That's important. And again, there's a lot of evidence, preclinical evidence that shows that timing is so important. So now, how do we intentionally amplify this plasticity in a safe and targeted way? We are talking repetition alone is not sufficient. Brain reorganizes in competing ways. And there is also, especially after the stroke, people also try to compensate for it, So whenever you're compensating, the pathways are different. So that we are competing with those, the compensating pathways as well. And so if we know all of this, how can we enhance safely and precisely? So that's the concept, the targeted neuroplasticity. It refers to pairing the brief neuromodulatory signals with the specific motor and sensory events, and it can amplify the effects of task-specific training. And there are many other, which is outside the scope of this talk, but vagus nerve stimulation is one proven, well-studied plasticity targeting approach in stroke, and now actually it is FDA approved for upper extremity motor recovery. What happens when you pair the VNS, vagus nerve stimulation? It activates the respective pathways. You can read it: nucleus tractus solitarius, cellulus, and basal forebrain. As a result, it releases the neurotransmitters, norepinephrine, acetylcholine, serotonin, and BDNF. Now, what happens when you pair it at the same time when the task is happening after the successful movement? It actually really helps. It makes sure it's marked in your brain as an important event and enhances the neuroplasticity and the recovery when compared to when it's done with the rehab alone. Now, let's say, what is the evidence? It's been studied actually for a long time, over 2 or 3 decades, actually. There are a lot of animal studies. I actually did this in a systematic review. It's very informative. You can find all the evidence at one place, both preclinical and clinical, by the time it was just published last year. Consistently, I was just surprised how consistently in all the animal studies of stroke, TBI, and SCI, paid VNS consistently improved the outcomes. They did it where, in some of these studies, they stimulated it before they did the rehab, it didn't work. They stimulated it after they did rehab, they didn't work. It only worked when it worked really well when they actually paired it with the task-specific training, and the closed loop, right? When the movement is happening, that's a critical part of to enhance the neuroplasticity. Now let's go back to human stroke studies in VNS. All these trials were done by the same team. There are overall 3 trials. The first one was like a very feasibility trial. Second was the pilot. And the third trial was the pivotal trial, which led to actually FDA approval. All these studies were randomized controlled trial. In 2 of these studies, except the first one, there was up to 90 days post-intervention follow-up. Overall, there were 156 participants, and they did it in the chronic stroke patients. I think in the earlier studies, they included from 6 months to 10 years, and then later on, I think they moved to the 9 months. And the primary outcome was the Fugl-Meyer score, actually, for upper extremity change. And they also collected a lot of safety and adverse events as well, and we'll go into that too. It's important to understand the inclusion criteria because right now in the FDA approval, they're really strictly adhering to these inclusion criteria. And they're not approving right as of now outside this inclusion criteria, except for FMA scores changed, I think, from F15 to 15 to 50 range. So the mostly included the adults, chronic stroke, people more than 6 months and within the 10 years. They have to have some kind of movement in the upper extremity so that actually they can participate in therapy, right? Because we said you have to pair with the task. If they can't do a task, very severe, you can't really do the rehab for them. And obviously, ability to communicate, understand, and give appropriate consent, and low spasticity, moderate. So, and unfortunately, most of the trials, we end up excluding severe patients, and so is the severe spasticity as well is excluded. What was the flow of the study? The people were screened. They did go ENT evaluation because, if they have a partial vocal cord fallacy or, silent aspiration or dysphagia because of the vocal cord paralysis, we don't want to implant, right? So they do go through the ENT evaluation. And then once everything is cleared and they consented, they go implant. And at the time of implant, they were randomized. And we did the second baseline. And that was actually the main baseline for the purpose of the study. And after that, they will get the 6 weeks of in-clinic therapy in which they were, get active versus SAM VNS paired with the upper limb rehab, 90 to 120 minutes per session, lots of repetitions of different tasks. Overall, 300 to 500 repetitions happened per session, at least 3 times per week, and total 18 sessions. That was the format of the pivotal study, and I think all the pilot studies as well. Now, once they finished the 6 weeks of therapy, there was a post, intervention assessment. And then the OT provided them a very patient-specific home exercise program. And they were also given a magnet. Unfortunately, I think their work is in progress. It will take some time. They're developing a new generation one. When they go to the home, it's very hard, right? If you ask the caregiver to provide the stimulation at the same time when they're doing the task. So right now, it's the magnet they go home with. They can activate the magnet. It continuously stimulates at a predefined period for 30 minutes. And they do their therapy and exercises during that time. At least 5 times per week for the 90 days. And then controls were allowed because you're implanting the controls to an FDA required this. So the FDA also required us to do a crossover, right? You don't want to just implant it and give them sham therapy and not do. So we allowed them to cross over once they finish the study and get the in-clinic therapy, and we will train them how to use it at home so that they can use it the rest of their life. This is the study device. The electrode is implanted on the left vagus nerve because the right vagus nerve have afferents to the heart and it can affect cardiac function or heart rate. So you don't want to. So it's very important that their left vagus nerve is intact. And, and then these electrodes are connected to an IPG, which is a battery is implanted. Dr. Tendon knows all about it. He helped me with my study. And it is subcutaneous on the left side of the chest. The system is once implanted, there is nothing attached to the body when we are actually using the system. It's controlled externally through the Wi-Fi actually, and you can stimulate it whenever you want it. And I think the battery life is 5 to 7 years, depending on the use. So they do have to go through a surgery to get the battery out. But I think, to my knowledge, that it's very hard to remove the electrode from the VNS. They keep it, even if they decide they don't want to use. Now, upper limb rehab. Primary principles: task specificity, repetition, active engagement, massed practice and variable practice. And we used different types of tasks. And depending on the patient's ability, it was customized for each patient. And each task will be performed for several repetitions, and they move on, to the different tasks during each session. The stimulation parameters, the current was 0.8 milliamp. It was based on what they studied in animals, and it worked in humans. Nobody had done the dosing studies yet. So I think just now that it's FDA approved, hopefully in the future, they'll look into dose as well. 30 hertz frequency pulse width is 100 microseconds. And training during each task, therapist will, I will show you a video. Will actually externally trigger it. And there is a very strict protocol when it has to be triggered, because the task has to happen. And once it's stimulated, the stimulation will be provided with the full 0.5 seconds. But the home dosing, it's a 0.5 seconds burst every 10 seconds for 30 minutes. Let me see if we can play this video. Let's see. So the therapist has a trigger in her hand, and she's going to look at, when the person is doing the task, and stimulates it.
The red button is the...
Yeah, the red button. Yeah, the red button is the external stimulus. And I think there is more engineering innovation can happen. Hopefully, I will talk about it. There's a one group in UT Dallas. They have developed a different system where we can even be more precise, where depending on some tools, it can automatically trigger, hopefully. And I think even the microtransponder is working on that system.
So it's a subclinical, like there's no clinical feeling or sensation from the trigger, right? It's all subclinical.
So there is, some people can feel it. Some of the patients in my study have told that they felt it and some couldn't feel it. But it's not uncomfortable or anything. They don't feel it like you're getting shocked and, some said that they felt.
The biggest thing is, so this is obviously very common in the epilepsy population, and they have it going on all the time. This is only turned on during therapy. Mm-hmm. In those individuals, that, especially when they're singing or speaking loudly, that's when they feel it in their voice pitch change.
Yeah. We'll go over the adverse events, and I'll see what other things we have experienced in some of the patients. So this was from my systematic review. It's the improvement in FMA scale compared to the controls, okay? Or the blue bars are post-intervention. So there was, if you do 8 to almost 28 to 13% more improvement compared to the controls. It's a relative change, so if they had additional improvement compared to the controls, and it seems like even at 90-day follow-up in the other studies, there was even more additional improvement at 90-day follow-up. Compared to the FMA. And then there is FMA scores. And actually, this group, I don't have that data right now, they ended up following up them for another 1 or 2 years. It seems like these improvements, as long as they were using it at home, it continued to improve actually. So there was much more improvement down the road with the long-term use at the home settings. So in the stroke pivotal study, there was one patient had a vocal cord paralysis that did require some intervention after a few weeks, and it resolved actually down the road at the follow-up. But besides that, it seems like there were no other surgical risks or any side effects happened related to STIM. Now, no serious adverse events, but let's say what are some of the side effects they felt? Some of the people, there was some pain at the post-surgical, right, at the incision site. Some people had some hoarseness initially, but that resolved. Some swelling, some cough, and throat irritation. In my study, personally, actually, I noticed that especially up when we are starting with them, the first couple of days when we are stimulating, they're having some, they'd cough actually, but then it resolved after 1 or 2 sessions. They didn't have any further cough. I mean, infections, we know that, well, not observed with the BV-STIM studies, but we know with the VNS, I looked up the literature because there's epilepsy. It seems like the infection could be, a possible risk in these people, but didn't happen during the studies though. So this was a pivotal study that actually TR Memorial Hermann was under the UT, our department was a part of this, Dr. Francisco and Nureya was a veteran. And this is what it was published in Lancet and led to FDA approval in 2021. Now, let's say clinical pathway in practice. So patient right now, these are the criteria the patients will, so they did, the microtransport went and they identified all the CPT codes, whatever is needed and approval from the, with the Medicare. And they are very involved still to help, people get approval. If you identify that somebody is really, is interested, as of now, they're providing a lot of support as far as I know. So usually once we identify it as of now, and maybe, Dr. Sharrief can tell us how it works at Neuro here, but in our department, and we are actively screening for the people with the stroke. And once we identify them, I think there is a pathway, with the Dr. Tendon's office. And there's a pathway then which we can, talk about offline if we needed, how to get them implanted. And then we also have to make sure they can actually get the intensive rehab. One of the criteria, right? If you implant them, if they can't get the rehab, there is no use for that. And as of now, we are happy to follow them at TR Memorial Hermann. I have at least 6 patients from my own spinal cord injury study. I see them in the clinic all the time. They use it at home, even outside the study, even when they're done with the study. No. Now, what are the challenges to clinical translation? Obviously, cost. As I said, what I heard, that insurance is still a challenge. It's a new, right? They're still learning, they're figuring it out. So there is still some challenge, but there is a support available, and also access to trained therapists, right? We have to make sure therapists understand how to use it. So I know at the Kirby Glen, where we have a main care outpatient therapy, we have already done the training. They know how to use it. They know if it's a BNS, patient, how to use the protocol. But maybe we can, overall the knowledge so that it can nationally be used everywhere. It can be, maybe more education. And a possible surgical risk. A lot of patients, they want to exhaust everything, then only want to go for the, invasive option. And unfortunately, more severe patients wants to get this than, the moderately impaired whom we have studied, reimbursement and scalability. But anytime any new system comes, there will be challenges. And over the period of time, as we gathering more and more data, it becomes the mainstream. And, lot of things are not mentioned here, but VNS is being studied in for pain, decreasing inflammation. It seems like it has a multi-system effect. And I've seen my patients, who have enrolled in the SCI, they look so much better. Their mood-wise, I think it definitely affects the mood it's a parasympathetic nervous system, right? Autonomic balance, even like meditation itself actually balances the autonomic nervous system, increases the parasympathetic activity. So I think it has much more than what we are seeing motor recovery as we going to start collecting the outcomes. I'm just going to go, right now we are also doing a study. It's not FDA approved in SCI. Everything first gets studied in stroke because that's where the money is, right? SCI is lower number. So people, all the studies are left for investigators to do it. So I picked up this, I'm like, okay, I'm going to do this for SCI. And we did our first pilot feasibility in the country, in SCI at here. It was a first very small study, safety and feasibility. We had a very small money. I'm grateful to Dr. Tendon to agreeing with me for the minimal cost to help me implant these and to even, get some data so that we can get the bigger grants to get this. It was very similar to what we did exactly stroke, We said we're not going to invent anything new because this is the first feasibility study. The sample size was supposed to be 8, but obviously because of the budget regions, we could only do the 6, Again, cervical patients, incomplete, at least 12 months, and within the 10 years of SCI, all the adults. I'm going to quickly go to, we did the randomized 1:1. Same way we have allowed them to cross over. Quickly going to the results. So you can see most of them were C and D. There was one person with a B, all adults. So we didn't have, actually in SCI are the more risk of having issues, right? If they have any ACDF, actually, especially on the left side, I remember one time there was one very complicated case where there was a scarring, it seems like, and ENT had to be involved. I think it's large surgeon dependent too. We didn't have any surgical risks or anything, it went very smoothly. So I was surprised because our patient population is higher risk of having some of those complications because of the cervical surgeries that they go through. And, so no surgical complications at all. The therapy related, as I mentioned, there was a cough in at least 3 subjects during just those initial sessions. But once, after that, they didn't have any cough or none of our patients had any hoarseness of voice. There was one patient had bladder spasms, but I don't think it was related to VNS. He had some catheter issues. Once that we took care of it, it went away. So our patients are actually in SCI doing very well. Most of them were compliant with the clinic therapy, but in our population, the home exercise program compliance was low. And that's another thing that, we're thinking about developing more telerehabilitation models to improve. It was a very small pilot feasibility study. So in the active VNS, so GRASP, so we use GRASP, for outcome measure in spinal cord injury. And usually change in a score of 6 or more is considered minimally, important, clinically important difference. And 2 of the active VNS group had, you can say the subject 1 and 6 had more than 6 score. Subject 3 did not improve, and actually he ended up getting a Botox injections. So since it's the investigator initiated, I also include people with the severe spasticity, what happens actually. But that patient did struggle a lot to participate. And I think you should optimally control the spasticity before we enroll anybody. That was a learning lesson for me. And he ended up getting Botox. So that's the reason that did increase, his function in upper extremity. And in the sham, we didn't find anybody, this remained stable and maybe slight improvement, but didn't have anybody and, any clinically important difference. But again, the main purpose of this was pilot, feasibility. But what we noticed, some of these outcome measures don't capture everything, Many of these patients improved smoothness. I think there is a room for kinematics actually, which we are thinking will include in the future studies. The smoothness and improvement in the moment. There were tasks that we couldn't, capture through the GRASP. They said there was improvement in such of these tasks. So qualitatively, we noticed a lot more improvement than what we see through the quantitative in the GRASP actually, what patients could do it. So they were all very happy. And personally, actually, in some of these patients, I noticed improvement in spasticity too. Obviously, that was not an outcome. So I definitely think it has a lot more to offer than just a neurorecovery. So in future studies, hopefully we can capture all of that. So as of now in SCI, we know it's a safe, feasible, well-tolerated, no serious adverse events. No post-implantation attrition. And it seems like there is a signal in SCI too, and we need to do more bigger studies to study the efficacy. Just before I finish, I wanted to bring your attention to another system that UT Dallas, group is. They used to be part of the UV-STEM. I think some of the investigators decided to do their own thing, and they went to UT Dallas. So they developed a different closed loop VNS system. I think this is the engineering, a little bit more advanced. So they just implant the electrode. They don't implant any IPG. It seems like it's a very minimally invasive surgery. And then they have to put this like a collar you see here on the neck to stimulate that electrode externally. So there are own challenges with it, right? If the patients have a lot of scar and subcutaneous tissue, we don't know. In the current system, we know when we stimulate, they're getting 0.8 milliamp current. But whenever you are adding more variables, we don't know how much current they're getting. And not everybody may be candidate for this system. But they also developed the toolkit actually. When people are using those toolkits, depending on, certain activity, it will automatically stimulate the system. Nobody has to stimulate it separately. So it makes it with the home use is so much more, easy when people are using it. So that's an exciting advancement. And they also found actually, they enrolled 19 subjects overall. And it seems like the red is the improvement after the VNS. They also saw the improvement, and this study was done in SCI. So it seems like there is a signals and consistent results were showing that VNS can improve the motor recovery. But key takeaways is that neuroplasticity is modifiable. VNS can amplify the task-specific training. So strong evidence in stroke and FDA approved. Emerging promise in SCI, and pairing and timing are everything. All right, I just want to acknowledge our research team. As I said, Dr. Tandon was the one who did the implants for my SCI study. And we're hoping to submit a DoD grant too in the future. So thank you, everybody, for listening. Questions?
So is the Dallas group using the SetPoint medical device?
No, they invented their own.
They have their own.
They are the one who actually, Dr. Michael Kilgard and Seth Hayes. As I said, they were part of the microtransponder. They're not using any commercial devices. They actually developed this chip. Yeah. I think you are involved in that too, the training or something. Yeah.
Well, the SetPoint is now a company. That's the one that's doing it for rheumatoid arthritis. But we've talked to Hayes. I didn't know that it was a different product. I thought it was the same.
No.
Because the concept is the same, that you essentially have the electrodes and a capacitor and a small amount of electronics in the neck, and there's no generator. Everything is inductive.
Yeah, okay, it's the same. Okay.
The concept is the same, so I'm surprised.
And I forgot the name. They have some specific name to it. Yeah, but there are challenges with it too, right? We have an external collar, so they had to exclude some patients too, because if you have a thick and short neck and you're really difficult. So I think it's good to have different systems and patients can choose which one will work. This microtransponder we know for more reliable, but options are always important. Patients prefer, I'll tell you, patient prefers minimally invasive. They don't want to go to surgical unless absolutely is needed.
Yeah, so also you talked about mood. Some of you may not be aware, but the company that owned VNS originally, Cyberonics, and then got acquired by Levanova, had gone through a whole pivotal trial of VNS for depression. And that trial was successful and showed that VNS therapy was very effective against depression. But the CEO got into a drag-out fight with the FDA, and the FDA won. And so the device never, it got FDA approval, but never got CMS.
Yeah, that's what I'm saying. But it has FDA approval.
It has FDA approval. They've actually implanted 2 VNSs for depression. As well.
Yeah, you had it.
I'm just surprised that people are so worried about the operation. If I had a stroke and weakness, I would be jumping all over this potential therapy. So I'm a little bit surprised that you're getting some concern from patients. Just as someone who's
I can tell you from spinal cord injury perspective, backloop and pump therapy for spasticity works amazing. I mean, I feel like this is an amazing, was whoever invented it. So by the time they get to that stage, yesterday I asked one of my patients, like, tell me why you don't want this. He said, I have a rods in my back, I have a suprapubic catheter, I have an ostomy, and I had trach. I just recently got rid of trach. I don't want another foreign device in my body. They feel like they've been through so much. Eventually they do come back, eventually. So they struggle. It's hard for us, no matter how much we treat them, to put ourselves in their shoes. Having just an idea of another device in their body implanted, it really, but also, and then you go back and explain them that how the risks and benefits and what's going to happen. Most of them, they do come around, but there's a lot of resistance, actually more in SCI than I think in the brain injury and stroke, because the caregivers are making, when caregivers are making the decision, they want to give everything to the patient, right? So it's easier, but I noticed when patients are making these decisions, they said, my God, I've been through so much. I don't want any more surgeries.
And on the stroke, the focus is the hand improvement and arm improvement. Why not leg?
They are doing the studies on the legs now,
they are.
actually. They are
Okay.
doing it. Yeah, they're doing it.
When they designed the study, that was the end point that.
Okay.
Yeah.
So now people are looking.
People are looking into GATE. It seems like early results. I mean, it's the same thing, right? Same principle. Because I think they went by there are a lot of surveys, like what is most important for the patients. I think upper extremity recovery ends up always being the most priority. So I think they went with it. And now they're studying for the GATE also.
But one last question. So if there is improvement in the upper extremity, is there any studies looking at changing the stimulation frequency to further improve it once you have it in? Meaning, can it improve more than what you've already demonstrated?
So they did. If you go to the Dallas slide, I know we didn't go into that. This study is the only study. What they did, if you look at these first graphs, they just gave 18 sessions with active VNS, and then 18 sessions with the SAM VNS to the control. So you see the control didn't improve, active VNS improved. Now they took both of these two groups. They gave now the control group an additional active 18 sessions. And also the VNS group got additional 18 sessions, and they say more improvement. But the problem is, of course, you can do everything. In reality, how do you translate this? I think doing that amount of intensive therapy for that long, but obviously it's good to know, right? Access to care, some people can afford out of the pocket. So they did find more when they did the more, actually.
So more stimulation, still more improvement.
More improvement, yeah. They did.
The big confounders in all of this are always the presence of physical therapy. And I just, again, we're obviously advocates for this, but there is a confounder that the people who are getting the device are also getting physical therapy. And in the original trials, people, it was against no device and physical therapy. So there was a control group, but all of these are uncontrolled now.
Yeah. And I will say that the barriers are a bit different in the stroke population. Especially, so I think you guys end up following the more severe patients. We end up following the patients who aren't as severe and end up in the community, and they are actually really interested in it. It's just kind of access for them, like how. So that's what I'll talk a little bit more about, pathways and barriers and in the community, because they're with primary care. Very few of them are with stroke, and very few of them are with PM&R. So how do you get it to them who are likely potentially interested, but just don't kind of have access in that?
That's true. So thank you for bringing that point. You had a question.
A lot of the recovery and spinal cord injury happens like within the first year afterwards, and like the intensive therapy post-acute, being in the hospital. How early are you guys how early ideally would you like the VNS to be implanted?
So as of now, in this purpose of the study, we did after 1 year, because we do see a lot of recovery happening during that 1 year. It would be nice to do during the acute stage, but during that time, they also have a lot of autonomic instability, and it takes around a year for them to do that. But I think once we know if it works, maybe down the road, we can explore if we can do it sooner, and these are the people might get more benefit.
Yes, one
last question.
Does the stimulation itself have adjustable intensity, or is each stimulation the same intensity, just different frequency stimulation?
It's the same intensity, 0.8 milliamp, and same frequency with every task. It's the same throughout the study. I mean, that's how it's device is programmed. But I think we should look into dosing as well, because dosing studies has not been done at all. I'm not sure why they just stuck to, based on animal studies, they stuck to 0.8 milliamps. I think that will be the comparative effectiveness studies down the road. All right, thank you.
And then you guys, I'm gonna sit. So my different mobility right now. So as mentioned, so most of you guys know me kind of as the prevention doc. I round in the hospital less now. I do some outpatient care, but much of my work is focused on improving systems of care for individuals with stroke and improving access to care. So I'm going to talk a little bit more about moving from innovation to implementation, how do we get our patients access to treatments that we think are beneficial to them. And then I'm going to talk about this learning health system framework that we use to think about implementation. So these are my relationships. So as we know, we've had some tremendous advances in stroke care, I would say even over the past 10 years, 12 years since I've been here. So mobile stroke units with acute care, multiple advances. Recently, we've heard about factor 11A inhibitors and their potential tremendous benefit for secondary stroke prevention, and then VNS and even other technologies to improve stroke recovery. However, with that, we have really some tremendous opportunities in stroke care, both on the acute side, but especially what I focus on is in secondary prevention, tertiary prevention, addressing some of the complications of stroke, community reintegration, so getting people back to the lives that they had before stroke, and then stroke disparities that really exist across the continuum of care. And these disparities are related to lots of different things, including whether they're living in rural areas or not, age disparities, sex disparities, multiple different disparities. Whenever I kind of give this talk, I talk about things from the context of the continuum of stroke care. And, a lot of where we work is in the hyperacute and inpatient space. But for the patient, their journey kind of starts way before that and continues on for a long time after that. And so a lot of the work that I do focuses on post-stroke care, kind of addressing many of the needs of patients, and also making sure they have kind of access to the services needed in the chronic post-stroke period. So there are, and this is just kind of laying the framework for how we kind of integrated the VNS pathway into our greater system of care. So there's no requirement. So what we do here is very different from what's done in terms of stroke follow-up and stroke care for most of the country. So there's no requirement for stroke centers to provide or facilitate follow-up. Less than 60% are probably lower than that for some of our patients follow up with primary care within 1 month of a stroke. Less than 15% will see a neurologist at any point after their stroke. And there's very low participation in outpatient therapy services, despite high rates of discharge home. 30-day readmissions are really high, and these services decrease 30-day readmissions if they're seen early. Medication adherence is poor. Risk factor management, unfortunately, is pretty poor in our patient population, which is what brings them back into the hospital. They usually don't get their orders for outpatient therapy services, and they're not able to reintegrate into community because of barriers with return to work and driving, and then also a lot of the mood disorders that we see. So up to 10% of our patients will have another stroke in the first year after stroke, and 20% will have another cardiovascular event, including stroke or cardiovascular mortality within a year after stroke. So we see them coming back in, but a lot of times they go to other places, they come in with an MI, and lots of this is related to gaps in access to care in the period after stroke. When we talk about tertiary prevention, from the standpoint of stroke, it's really addressing these factors like motor recovery and a lot of the other factors that were mentioned earlier. So 50% or more have persistent motor deficits at 6 months. However, outpatient rehab intensity and access is very below guideline recommendations. We have cognitive impairment, mental and psychosocial health challenges, and then community reintegration. We see lots of younger patients with stroke, and returning to work for them is really important. However, they're not able to because of a lot of the things that you see at the top. So these are kind of all the things that we think about in our program when we think about post-stroke care. So it's not only secondary prevention, it's also the recovery component of it. It's also complication management and community reintegration. And that reintegration part, we initially really focused on the green part, like this is what we have to do. But for the patients, everything else is what really matters and what they want us to focus on. So we have taken what's called a learning healthcare systems approach. And this is what much of my kind of research and kind of national work focuses on, thinking about how we innovate health systems and kind of continuously learn from what we're doing to improve patient care. So the components are, the main thing is continuous learning, kind of this idea of we're always learning within our healthcare system. Team-based science is really integral. Patient and what we call community contracts or community community engagement is really integral. And then we also want to make sure that the healthcare delivery incentives are aligned with the learning healthcare system goals. And that part is often the most challenging part, kind of getting access to care and kind of equal care to all our patients sometimes isn't what's aligned to the delivery incentives. So sometimes we have to kind of change the way we think about those incentives. So this is kind of our model with person-centered care at the center, and then research, community engagement, team science, and learning and mentoring are key components of it. And this all kind of is under the umbrella of our STEP programs, or the Stroke Transitions Education and Prevention Clinical and Research Program. So this is kind of what I was brought here to develop in 2013 or so. We started doing a registry in October of 2014. And I mentioned that we initially focused on risk factor control, but then really expanded it to be a lot more than that. So over the past 12 years, we've treated more than 12,000 patients with stroke and continue to follow many of them. Initially, it was just me and a nurse practitioner. Now we have 5 providers every day at TMC, and also now at Southwest and Memorial City, kind of providing access to post-stroke care and then longitudinal stroke care for individuals in the community. And like I mentioned, this system is not a system that is common or is practiced in most places, although we're doing better. So the components of it are clinical research design and enrollment. So research is a really important part. We have enrolled 1,500 patients in clinical trials just for stroke prevention and recovery over the past 10 years. And we have multiple of our own investigator-initiated studies. Many of them are related to prevention and recovery. And so whenever everything we think about research and how we can learn from what we're doing. So we've built other programs, including our heart-brain programs that are nationally known for PFO clinic and cryptogenic stroke follow-up. And then the VNS pathway is our kind of most recent pathway. So that was, again, just to lay the framework of how this kind of works within our program and some of the components that you have to think about when thinking about barriers to implementation across other sites that may not have the same structure that we have. So the components are identifying champions and aligning the team. And these are, components of developing any pathway, an inpatient pathway, any type of pathway. These are similar components. Agreeing on the patient's pathway and the plan, communicating and launching the pathway, and then meeting regularly to assess, troubleshoot, and optimize. So here we have identified champions in neurology, neurosurgery, physical medicine and rehab, physiatry at TIER, and then our medical staff. So our medical assistants are the ones who really are making sure the patients are moving through the pathway. And then I would say we have research team members as well now that we are engaging in research with this. And then of course our stakeholders are many more. So patients and caregivers, number one, academic and community neurologists are, I'll talk about some of the challenges for those that we need to reach out to. Primary care providers, again, are taking care of most of the stroke patients in the population. PM&R providers, advanced practice providers, and then outpatient therapy providers, and probably multiple others. So the first thing that we did was to develop kind of a patient criteria based off the evidence. We wanted to make this easy for the providers to say, let me look at this and see if my patient is potentially eligible. We didn't want them to have to do Fugl-Meyer in the clinic or anything really to disrupt their clinic flow. And so we kind of had this kind of general criteria. Look at your patient. If they fit these criteria, then they're potentially eligible. Talk to them about it and see if they're interested. So we developed this criteria, and then we educated our entire department on the criteria, kind of starting with the stroke outpatient providers. These are our
for neurology or for PCPs.
So this is for us. So we started it in neurology. Yeah. So
You said that most of the people providing stroke care are the community
right.
primary care physicians,
Right.
not neurology.
Right.
So that's a big capture.
Yeah, so that's where I think the opportunities are. So what we have most access to and where we can probably capture the most buy-in early on and kind of demonstrating that this is effective and works are with the people that we have most access to. And then as we kind of refine the pathway, kind of the same thing we did with our heart-brain pathway, we made it really just centered at the medical center. And then we started to expand to other people. And I think that's where really the opportunity is going to be for expansion. So, and then the steps are, it's a lot of steps at present. And this, we kind of got it narrowed down to this number of steps, but you can see how complex it is. So we are asking people to, our neurologists didn't really want to, outside of stroke, didn't really want to try to assess eligibility or talk to patients about it. They didn't feel like they were empowered to kind of talk to patients about it, which is another opportunity, I think. So they're sending them to us to evaluate them. And again, we have 3 sites and 5 providers. And then we review the eligibility. They kind of refer them to us for secondary prevention optimization and, VNS evaluation, just so the patient knows that they're getting more than just that. And then we review the eligibility, discuss it with the patient. I would say for 75% of the patients that I bring it up with, they're kind of interested in learning more right away. And then we can kind of put them on the pathway without doing the referral. There's a kind of navigator process, a patient companion process where they can learn more about it. And then we kind of leave it to our MA to put the referral to OT in, rapid referral to OT at tier, and there's a pathway at tier now for Fugl-Meyer evaluation. And then there's a VNS coordinator who kind of co-follows the patient from that point to make sure we don't lose them. And then they have the OT evaluation. Coordinator tells our team, re-refer to neurosurgery after that point. They kind of wanted us to and refer to neurosurgery immediately, but we were concerned that there were going to be so many patients that were ineligible and we didn't want them really being referred, but that's something that we can think about. And then you guys evaluate them. The authorization part can take a while, but maybe less time now, especially if they have Medicare. They're scheduled for implant and referred for the registry, which is, I think, a really important component of it. The implant's completed, OT scheduled, outpatient therapy initiated, and then they're followed in the registry to track outcomes. So these are the current steps. It did take some time to kind of get all of these different components and everyone on board with these steps. This is the implementation timeline. This is quite rapid, I would say, for typical implementation timeline for these types of things. So we were doing referrals before the pathway was kind of in place, but it was kind of just like a one-off. But then we wanted this to be so that it was more coordinated. So in November 2024 is when Christina Kim kind of took the reins of it. We got all the stakeholders aligned. We drafted the initial kind of like protocol. So we have kind of like a protocol. It was finalized, the pathway was launched in May. We continued department education. The first VNS pathway patient was implanted in August, I believe. And then the registry invitation. So we were invited to join the registry with microtransponder in September. And then our first registry patient was enrolled in November of 2025. So it's still early, but we have at least 13 patients, probably more, initiated on the pathway. 5 patients, maybe more, implanted, 3 patients enrolled in the registry, and this timeline. And this is, I mean, this for a pathway that just started, this is reasonable, but for the number of patients who are eligible, like this is very much lower than potentially it could be. The early challenge.
The ones that we implanted before the pathway can't be on the registry?
So they cannot, they want them to have a Fugl-Meyer like at a close time before implant. And because many of those patients were waiting for
I see.
a while, they don't want us to use the Fugl-Meyer that they had for enrollment.
But it's a chronic stroke.
Right, so it's not gonna change. So we've been communicating with them about it because we have so many other patients.
Yeah, there's at least another dozen.
Yeah, that we should try to get those as well. So I think maybe they'll be flexible with it, but that's something we've talked to them.
So are they obligated to have this registry by the FDA, or they're just doing this voluntarily?
I actually am not sure.
Maybe post-market approval.
Maybe so. But they are giving us some like support, financial support to do it. Yeah, and so like the OT, there's an outpatient OT that we are working with. And also tracking some of those other outcomes, I think that may be important, like depression, anxiety, some of the mood-related outcomes. But then also, I think giving that, I think for some of our providers, that feedback about how patients are doing is also going to be important, just to kind of continue to engage individuals.
That score track also gait? Out of curiosity? No, it's only on extremity.
Yeah, yeah,
So, but you don't track gait, even though they probably have some gait. deficits.
probably. And I don't know if the registry does. That's something that I can look into. Yeah, yeah, I can look and see if the registry does, because an OT evaluates them. So they may be looking at other
Yeah,
outcomes
something.
too.
May
Yeah,
not be
yeah.
like Perfect, but.
Yeah, they have quite a few outcomes that they're tracking. And yes, a lot of our patients are like, well, is it gonna help my walking? So, you know, so
And
I
my
think,
speech, that's
yeah,
the other one, because
yeah.
it's a dominant, I mean, in general, the people who are motivated to do this are the dominant hand. And so therefore language is affected as well. And that's another reason I'm really interested in these
Yeah.
people, because, you know,
Me too.
highly motivated aphasics.
I think it's so much, and then ICH is a whole other story, but I think there's so much more, you know, opportunity if we can show evidence and access, I think, you know.
Now, we have embedded a few ICHs as well.
Have you? Because I have some patients who are ready.
I
You
have,
know?
and I tell them, look, there's no, the trial was done on ischemic stroke, not on hemorrhagic strokes, but
Yeah, I mean, there's like nothing for them, so, you know, maybe we can talk about, but I have some who are really interested. So these are some of the opportunities, and I just have them, most of them I talked about. Education and referrals from just neurology in the community, I think is where we might start, and then reaching out to primary care after that. We have talked about having a VNS clinic, so we have heartworm clinics where everybody comes on the same day, and that's really shortened the time and made it easier for patients. We have virtual and kind of like in-person access for those clinics, but we would need to have kind of like, and really it would just be getting the evaluation with us and the OT evaluation at the same time, so then we can just refer to neurosurgery from there, which I think is possible. It's just getting the volumes to make it, you know, make sense. There are multiple access and implementation barriers. So the patient ones, and most of it is related to awareness as an option. And so I think there's opportunity for us to activate patients in the community and talk to them about it. And then some of the other things that are just barriers to patient care in general after stroke. Provider factors, that's a big one. So limited familiarity is the biggest, I would say. And then the uncertainty about the benefits, but I think that's just education. And then competing priorities, kind of making it easy for them. And then structural and system factors. You know, some of my patients live very far away and they don't really have access to implementation close to them. Like I have people all over the place. And so that's been one thing, trying to make it easy for them to get here or to get, you know, somewhere where they can have the implant. So the gap is really, you know, high residual post-stroke disability, fragmented post-stroke care, and underutilization of recovery interventions in general for this population. But we know the stroke patient population is growing. I think even though we're doing much better with acute inpatient care, there are going to be lots of people with some residual disability. Prevalence is continuing to grow as the patient population gets older. So there's a lot of opportunity, I think, in the future for this. The learning healthcare system opportunity is to think about embedding pathways into longitudinal stroke care, aligning our teams better, tracking real world implementation, and just looking at the data continuously. And then of course the vision is a scalable model. And there are so many opportunities for research in this space, even implementation science research, in terms of how you kind of expand this. So probably within, you know, we'll submit something to the stroke conference about our pathway and the experiences that we've had, you know, so far. So that is everything for me, and I'm happy to take any questions. This is our team. If you guys have patients that you think, I mean, it's probably easy for you guys to get them, but if you have patients that you think you might be interested in us seeing from a prevention perspective or other evaluation perspective, please send them. If you have any difficulties getting patients in, just let me know. Again, I'm at Southwest now as well. We're at Memorial City. And so we're all over to try to make it easier for our patients to get to us. Any questions? Any more questions?
What can't VNS do? That's it. We do everything now.
Well, I would just summarize it like this, right? So there's clearly a neuroplasticity component of some kind. How robust that is going to be, I think really time will tell. There's an accelerant from the industry and because these devices are approved. But they're also in parallel, right? Stroke, there are two other interventions that I think, you know, germane to this discussion. there is a trial for cerebellar stimulation, dentate nuclear stimulation that Andre Machado spearheaded out of Cleveland Clinic that is now at its first multi-site evaluation. So we'll see how that pans out. And then Jeff Wojerman is doing a variant of what used to be the Everest trial, a failed trial of motor cortex stimulation for stroke recovery. And he's implanted a couple of patients now. I sit in that DSMB and know Jeff really well. I'll have him come down and visit again. But I think, there's not been any therapy for there's been a lot of developments in acute interventions for minimizing the impact of a stroke, thrombolysis. And then, but in the post-injury state, there's been nothing. There was a little bit of stem cell work early on. And so I think it's gonna be an interesting decade ahead.
Yeah. And I think we should also think about leveraging I know we think about it being focused on dementia, but I think we can expand it to thinking about stroke and recovery and, right. So I mean, and I also tell my patients, I'm like, this is not gonna make them go back to baseline. You know what I mean? Like, I try to make sure that I communicate it as something that can help and can kind of improve function in some ways, but not something that's gonna reverse the injury that they have. But I think some patients are just looking for something because we haven't had anything for so long. So it's worth offering it and kind of,
But thank both our speakers. Thank you so much.
Thank you guys.